Namaste. Welcome you all to this very exciting program of Gyan Pravah. I, Dr. Bharti Rajshekhar, the chairperson of the Fogsi Perinatology Committee, I'm indeed thrilled and honored to have Dr. Sunita Tandulwadkar, the president of Fogsi 24-25, and Dr. Purnima Madhivanan on this very important podcast. To start off, I would like to say a few words about Dr. Sunita Tandulwadkar. All of you are very familiar with her smiling face, charismatic and bubbling with energy always. Dr. Sunita is the head of the Department of Obstetrics and Gynecology at Ruby Hall IVF Center in Pune. And she has been the founder president of the Ovarian Rejuvenation Society. Madam has various accolades to her credit. She is the president-elect of ISAR. She has been the past president of IAG. Though she is an advanced laparoscopic surgeon, she has her heart and mind and in bringing about improvements in the basic health of women of our country. That is reflected in her programs which she has put up for her presidential tenure. That is the Sampurna, which focuses on preconceptional care and maternal nutrition throughout preconception to lactation and the first 1,000 years of life of the neonate. And also she has brought about the Know Your Numbers, which is a very innovative project where every individual needs to know their height, weight, BMI, their blood sugars, their thyroids, so that they have a healthy base. And Madam has also taken a step forward in the cancer cervix prevention program by bringing up the program of Do TK Zindagi Ke. And I am indeed amazed by how she gets the perfect tagline for whichever program she takes up. And the latest on the block is the FemiCare, where all of us are taking a pledge to get a place in the Guinness Book of Records that we will all care for women, especially the preconceptional care. So over to you, Dr. Sunita ma'am, to say a few words on this podcast. Madam, you're muted.
Thank you, Bharti. Thank you for your generous introduction. But it's lovely to know about Purnima ji. And Purnima ji, thank you so much to come on a Fogsi platform. It's indeed the great honor and a pleasure. And Bharti, you are amazing.
Thank you.
I have observed you as a state president, the amount of activities and the amount of physical CMEs, the social project, giving the cancer vaccination, absolutely amazing work you have done.
Thank you.
And coming to Fogsi was your extension from your society to state to the national level. So you are doing amazing. And Purnima ji, this is our podcast series. Every day, 8 p.m. we do. And we are 30 chairpersons. So 30 chairpersons have been given 30 dates. So on the same date, every month, these chairpersons have dialogue with one of the faculty. It may be academic, non-academic, Indian or international, where they educate, this is seen or viewed by even the gynecologist and even the lay people, because it's going on a YouTube, Spotify, Facebook, everywhere. And believe me, these are our future leaders, and the way they are choosing the faculty, the subject, so that it will be one of the best podcasts of that month they try to do. So I'm thankful to you, Bharti, for always making very good podcast. And as our protocol says, once you introduce Dr. Purnima ji, I'll view you all from the different link.
Yes, thank you, ma'am. Well, Dr. Purnima's introduction would run into 20 minutes, but I will cut it short to about 2 minutes. So it is indeed an honor to introduce Dr. Purnima Madhivanan to this podcast on cancer cervix, the facts, the fright, and the future. This will be the discussion. Dr. Purnima Madhivanan is a prestigious alumni of the Mysore Medical College, where she graduated from. Later on, she moved to the United States, and she is right now the associate professor of at the Mel and Enid Zuckerman University at Arizona, Tucson, and she is an epidemiologist who has done various studies, and she is working towards studying the impact of health on this disadvantaged population of women globally. She has a special focus on the low and middle income group of countries, and India is also one of the main sites of research. And she has started the Prerna Foundation in her own hometown, Mysore, where she is rendering services to around 50,000 women of the resource poor women who are suffering from cancer and other HIV problems. And she has also received various awards and accolades to her credit, of which a few I will be talking about. She has, so she has been a peer reviewer for more than 200 indexed publications. She's an advisor to the Public Health Department of various states in the United States of America. And to name a few of the awards, she has received the Elizabeth Glaser Award for her work in HIV among children. She has taken the Fulbright Nehru Project, which is to advocate medical social needs of female cancer survivors, and she is working not only in India, in various states in the United States, as well as in the resource poor countries like Nigeria, Ethiopia, and other African countries. So it is indeed a pleasure to have Dr. Purnima. This is a very brief introduction of you, Dr. Purnima, but we would like to hear more from you regarding how we can go about to see that we can reduce the incidence of cancer cervix, especially in the low and middle income group of countries. And what is the fact? What is the fright that most of us have about this dreaded disease? And what is the promising future that you could guide us as that we can, along with Fogsi, take it across those women in our country and see that by 2030, we will be able to achieve the SDG goals as laid down by the WHO. Over to you, Dr. Purnima.
Thank you. Thank you, Bharti.
Thank you, Dr. Sunita, ma'am.
Yeah, before I leave, I just want to know, you said 50,000 women, they are from a Karnataka, Mysore region?
Yes, madam.
So, Bharti, these women must be doing their weight, blood pressure, hemoglobin, and sugar checkup. So these 50,000 women will be a large data to enroll in your Know Your Number, in our Know Your Number project. So can I request you, Bharti, to take this, because this is so much important.
Sure,
by just having the study of all. So Purnima ji, we are saying that the longevity has increased. So women living in 5th, 6th, 7th decade of life has become. But unfortunately, they are suffering with the chronic diseases, lifestyle diseases, obesity, diabetes, hypertension, knee joint problems everywhere. So we are trying to promote that doing your regular checkup yearly and overcoming if any abnormal report you got in, make it normal, change your lifestyle, and that will give you more healthy and longer life. So we are collecting the data of pan-India all women. So with your permission, if Bharti can do, this is just the simple Google form. It takes 10 seconds to fill up that form, and it will be of great help for collection. You never know, when we are collecting from all over India, we may come out with some fantastic results. We may be into the advocacy or policy making for the government. We may have. So it's just the way we are collecting. Anyway, this is your podcast time, so we'll catch up later.
I take it forward, madam. I will take it forward, Dr. Sunita ji.
Thank you. Thank you.
Thank you, ma'am, for your precious time.
Thank you so much. Thank you, Dr. Bharti. Thank you, Dr. Sunita. It is a pleasure and it is an honor for me to be able to come and share my learnings and learn from you all to make sure that we have a tomorrow that would be free of cervical cancer for all of us.
Well, thank you, Dr. Purnima. And now, going ahead with our podcast, let us start with the facts of cervical cancer, one in the global scenario, and what are the facts in our own country.
Well, when we talk about facts as an epidemiologist, numbers matter to me. And the latest numbers and the numbers that we can depend on come from WHO, the International Agency for Research on Cancer. They come out with the Globocon statistics, and the last statistics we had was from 2022. There were 662,000 new recorded cases of cervical cancer globally that year, positioning it to be the fourth most prevalent cancer among women worldwide. Now, when we compare that to India, cervical cancer ranks second most common cancer for women, with 127,526 new cases reported each year. So you can see a large burden of the incident cases or the new emerging cancer cases, cervical cancer cases, are from India.
India, yeah.
And India accounts for about close to 80,000 deaths of the 348,000 deaths that happen worldwide, attributed to cervical cancer. So it's almost 25% of the burden of deaths is attributed to India again. And when we look at the age standardized mortality across the globe, it stands at 7.1%, 7.1 per 100,000 women. But in India, we are at 11.2 per 100,000 women, which means we have significantly higher mortality rate compared to the global average. And all of these numbers are worrisome.
Yeah.
And the reason they're worrisome is because cervical cancer is completely preventable.
True.
If we work at it.
Yeah. So, Dr. Purnima, this alarming mortality rate, as you said, is really truly worrisome. So, what do you think are the factors which are contributing or which are responsible for these high mortality rates and the high incidence of the disease itself in our country?
Well, when we think about our country culturally, we have not given much attention to prevention. We do not screen for any abnormalities. So we have a whole bunch of issues we have to be thinking about. The stigma associated with the word cancer prevents women from wanting to go and finding out whether they do have cancer or not. So that is something that we have to address at every level. We have lack of knowledge and awareness about the condition. And even women who are aware, we have issues with access to healthcare services, especially in rural areas, lack of healthcare providers. There's also stigma associated with reproductive health issues.
True.
When was the last time any of us ever went and had a pelvic exam? It would have been probably when we went to deliver.
Exactly.
That's the only time a woman ever gets a pelvic exam is when she goes into a healthcare facility to do her delivery. So we have issues around it. And of course, we have financial constraints. And as I said, cultural beliefs influencing healthcare seeking behavior are some of the issues that we all have to be talking about if we have to address this dreadful disease.
The apathy, the lack of awareness, and the accessibility is major issues. Do you think nutrition and marriages at younger age group, repeated childbirth also contribute to this higher incidence of cancer cervix?
That's a good point. When we talk about nutrition per se is not going to be causing or being associated with cervical cancer. However, it does bring down the immune response in our body, which can then lead to the progression of cervical cancer. The other issue that we also have in India is because we don't screen often, by the time women show up with cervical cancer, they're in late stages,
Advanced
stage 3,
stage.
stage 4, at which point most of them land up dying early. So that kind of reinforces this cycle that people are scared that if you're diagnosed with cervical cancer, you're going to die. So we have to break that. And the only way we can break that is by actually trying to screen women early on and getting them at an early stage when it is still treatable.
Yeah.
So that it doesn't become a death sentence for her.
Yeah. I think the awareness programs have to be started much early in life, not in the middle age or past or reproductive, delivery and all that thing. I think we have to start talking to the adolescents, where they get to know that cervical cancer is completely preventable. So I
Yes.
think that is the awareness, because they are more, I think, receptive when we talk to them and keep on hammering them with these words of screening, vaccination. I think that will ring a bell in the family, and from word of mouth it spreads. I think that's what is.
Absolutely. I think for us, our country is very young. We have a very large population of young people with the demographic shift. If we can actually aim at health education at a younger and younger age, those messages will carry forward as these young people grow up and become
Yes.
children, from children to mature adults and have children themselves. I think that will move forward, and that is going to be a great thing for all of us. Health education at school level, focusing on preventable conditions. These are low-hanging fruit. The non-communicable diseases that we are dealing with are absolutely preventable because most of them are associated with nutrition,
And
physical
lifestyle.
activity, diet, lifestyle, exactly. And we have so many vaccine preventable diseases. So if we can kind of incorporate these ideas, sow the seeds at a younger age, hopefully we will get the fruits much later on.
Yeah. So moving to the global scenario, as you said, it is the fourth commonest cancer globally. But what do you think are the factors which have contributed to the reduction in the incidence of cancer cervix and the mortality associated with that in the developed countries or the developing countries?
So let me start with the developed countries. In developed countries, we've had very regular screening protocols, annual screenings, and then now with the new technologies that are emerging, we don't even have to screen annually. We can screen once every 5 years. So regular screenings have been the way we were able to keep a lot of these precancerous lesions in check. And once the HPV vaccine became available, there was general rollout of HPV vaccine, and it was a gender neutral vaccine, not focused only for girls. It was gender neutral. Everybody, boys and girls, could get it. These have actually almost brought the number of mortality cases or number of deaths in a lot of the developed countries to close to zero. If you look at the Nordic countries, you look at Australia, look at Scotland, after HPV vaccine was rolled out and with regular screenings, they don't even have to talk about cervical cancer anymore. So we have these ornaments in our toolbox. We just have to implement them now.
And do you, in the United States or the developed countries, do they follow is it mandatory, or is it by a consensus that the vaccination and screening are done? Or is it that the insurance company insist on having the screening done?
You bring up a very good point, Dr. Bharti. In terms of screenings, people who have insurance, they go in for their annual physical checkups, and then they're able to get their screenings done. The challenge is for those who don't have health insurance. What do we do? And those are the people we are working with. In terms of vaccination, many of the required vaccinations that people get for their children, the childhood vaccinations, are mandatory in order for children to get admitted into schools. However, HPV vaccine is not a requirement.
And that's
So
given
one
later
of
on
the,
also. It's given
yes, it's
later.
right. So one of
Right.
the challenges and one of the projects that we are working on is looking at what are the rates of personal belief exemptions, vaccine exemptions. So there are exemptions that parents can apply for before they can admit their children to schools, saying for religious purposes or for personal reasons, I will not vaccinate my child. And there are those exemptions that allow for some school districts to allow for these children to be admitted. Those exemption rates are going up across the board
Sad.
in the
Okay.
United States.
Right.
And that is again seen more, it has happened more after COVID pandemic because of the misinformation and
About
disinformation, and the vaccine hesitancy is leading to parents not even wanting to get the basic vaccinations. We
like
have 2 deaths associated with measles in this country.
because they fail to get vaccinated.
They would not get vaccinated. I can't even imagine something like that in India.
True.
So we have other issues in the developed world, which is, again, we have this moral issues around society versus individual rights. You can't tell me what I can do because this is
Yeah,
my right.
my right. True. So those are the
As
other
compared
issues.
to,
It's a different
if
thing.
it is your right, then stay in your house. Don't come out and infect others.
Exactly.
Is something that, we would have to talk about.
The others' human rights are transgressed.
Exactly. So there is that push and pull, that discussion that happens in the developed world. Now, why do we see high rates in the developing world? Again, it's lack of resources. In the developing world, it's not that women don't want to get screened, or it's not that, the kids do not want to get vaccinated. We have the interest, we are motivated, but we do not have the resources.
Yeah.
A vaccination costs almost a month's salary for some of the people working in some of sub-Saharan African countries that I work in. So they can't afford it. We also have this added complexity of HIV in a lot of these countries,
Yeah.
which increases the progression of cervical cancer. And if women are not getting screened, and if they are infected with HIV, their likelihood of progressing to cervical cancer is much higher.
It's much higher. True. Yeah, thank you, Dr. Purnima. So now I think most of the facts you have come across, you have put across, and of course the fright, you did deal about the fright that were associated. What is frightening, as you said, people are coming out and refusing to take the vaccine. The resources are the problem in many of the low middle income countries. And how are we going to tackle these issues? So I think we need to look at something that will give us a brighter future, and that we could, as epidemiologists, as obstetricians and gynecologists, as family physicians, what is the future we are looking at, and how could we put our hands together in various modalities and take it forward. So in the fright issue, I think in India, what I would say is, what is the issue facing is, as you said, resources and finances may be a problem, but the health budget allocation is something that really frightens us healthcare personnel, because as you said, there is the utmost, I mean, we just get about 1% of our budget, less than, just increased by about 0.8% this year in the budget for healthcare resources and prevention of these preventable diseases like HIV,
Right.
so like HPV is still in the backseat.
Correct. Correct.
So we are, as you said, you were there in Bangalore with us when we met the health minister. He was proactive with us, and we are looking forward. But still, they say we don't have resources. So, what's your take on
India is a very complex country,
that?
and the more I step out of India and come back into India, I find it even more complex.
Yeah.
And the reason I say that is because of the disparities that we have. We are the Silicon Valley for the world. We send out the most educated engineers and everything out into the world. We have the resources.
Yes.
It's not that we do not have the resources in India. We do have. So the fastest number of millionaires in the world are in India. Now we are getting billionaires in India. So we do have the resources, but the thing is where these resources are located.
Yes.
That disparity is what we're talking about. And for having said that, we cannot expect the government to solve all our problems.
Yes.
Government is doing the best that they can. They did come out with the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and stroke.
Yeah.
So they are invested. Our government is invested in whatever way they can. But that doesn't mean that all the other parties take their eyes away because we expect the government to do everything. We do have a lot of philanthropy that can be done. We have a lot of resources and money circulating in the country that can be allocated towards it. How about public-private partnerships? How about the CSR funds? How about partnering with Rotary? Rotary International is amazing. They were responsible for elimination of polio. So how about getting them to get invested in another vaccine preventable condition like cervical cancer and try to get other bigger agencies to invest and work together. And even us as individuals, we all have the power to make a difference. So I will not hold it on the government to say, okay, the government has only a limited budget, so how can we solve this? I think if each one of us does our part, we can contribute to what the government is doing.
Yeah.
And I think that's what we're all seeing with those meetings that you
true.
said. Yeah. We're all trying to do our part and we can make a difference.
That's exactly, I wanted this to come on the podcast because as you said, Dr. Purnima, we have taken up this project of HPV vaccination in my small town of Hassan since the past 5 years with the Red Cross, with the Rotary, and as our own obstetric and gynecological society. I first started the program as soon as even when we didn't have the indigenous vaccine, we said each one sponsor one. That was my program. And we first sponsored the children who were HIV infected. Because as you said, they are those who have less immunogenicity and they are the most susceptible to to the HPV infection. So we had about 50 children who were all HIV positive, which each one of us obstetricians and as you said, our friends, we sponsored the vaccination of one child. So the 3 doses, because they are supposed to take 3 doses, we gave them the 3 doses as per the schedule, and it was all sponsored by individuals. Taking it forward, we took in the Red Cross, and the Red Cross brought us funds where we could vaccinate 100 children for free. And just last month, we have vaccinated 2,000 children in Hassan district for free. In a very remote village in Arpulgur, we had our ex-politician who joined hands with us, said, I will sponsor some amount as a philanthropist. And we had the HDR Foundation under the leadership of Dr. Hema Divakar, which sponsored some of the amount. And the entire program was managed by our Hassan Society and 2,000 children were vaccinated for free. Similarly, the Rotary has taken up this program, as you said, and we, along with the Rotary, are doing a lot of camps around the country where we are getting philanthropists to donate money and the CSR funding, and we are vaccinating. So as you rightly said, the public-private partnership and the commitment by each one of us towards society, I think, can definitely help us achieve this goal of 90-70-90.
Yes, I think we need to talk about this 90-70-90 because I hope your listeners know what we're talking about when we talk about.
Yeah, I want you to talk about that.
Yeah, so 90-70-90's target or strategy for cervical cancer elimination by 2030 was introduced by the World Health Organization as a comprehensive approach to reducing the burden of cervical cancer worldwide. So the strategy essentially reflects on 3 key targets. 90% of the girls globally to be fully vaccinated with the HPV vaccine by the age of 15 years. 70% of the women to be screened with a high-performing test by 35 years of age and again by 45 years of age. And 90% of the women identified with cervical cancer or cervical cancer disease receive treatment, which means 90% of the women with pre-cancer are treated and 90% of the women with invasive cancer are managed. That's what the 90-70-90 strategy is, and WHO hopes we can eliminate cervical cancer by 2030.
So I think that's what we all should be looking forward to and joining hands to achieve this target, because many of the countries have already touched the landmark. And we are making very slow progress, but I think we need to go ahead and work on that. Well, now talking about the future, as you said, yes, prevention is by vaccination, screening, and treatment of the pre-invasive lesions. So vaccination, we know that the Fogsi guidelines are the regular 9 to 14 two-dose schedule of a quadrivalent vaccine, and 15 to 26 years or up to 45 years with proper counseling of the quadrivalent 3 doses vaccine. So this is the protocol I think you are also following in the United States and the other countries.
Yes, so in the other countries now, with the WHO SAGE advisory group has come up with a single dose schedule.
Yes.
Which has changed the paradigm for a lot of us, because HPV vaccination, there is major shortages in availability of the vaccine. Even with the Serum Institute vaccine coming up, we are still going to have major shortages for the number of eligible kids who would need the vaccine. So this single dose is very promising, and what they have found based on the studies is the 10-year immunogenicity for a single dose was just as good as a two-dose vaccination that was given. So in Mysore, we've actually given the nonavalent vaccine, and we have given a single dose. And I'm hoping that the guidelines would change soon to make the vaccination schedule to be a single dose so that more kids would have the opportunity to be vaccinated.
Yeah, I think that's what we would like to tell along with Fogsi, with Dr. Sunita Madam, and presenting to the government the studies which relate to the immunogenicity in the single dose by the SAGE study, as well as the double dose, because that, as you said, would be a huge impactful if we could just vaccinate them with a single dose at the age of even 14 years, when they are in their 9th standard or the 10th standard, entering the 10th standard, they take their single shot of vaccination. I think we could very, very quickly reach the target of the 90% of vaccination. I think in future, that is the promising step forward that I think we should take forward, because though the WHO has already given their guidelines, we are still a little apprehensive with this, though we are, as you said, these 2,000 children, we have given them the single dose vaccine, and we have also given them the facts that single dose is, as per WHO, said to be as potent as the double dose. However, because the Fogsi guidelines and our DCGI guidelines of India have not yet brought it in the protocol, if you wish to take the second vaccine, please come back after 6 months. So this is the message we are sending out to all those children who, if you wish, please come back for the second vaccine. And because, as you said, giving the second vaccine does have a huge drain on our resources. So we could vaccinate another bunch of children with that second dose if we follow the single dose protocol.
Absolutely. And another thing, Dr. Bharti, that I want to bring up to everybody's attention is we are talking about a quadrivalent vaccine, which has 16 and 18 as the high risk.
Yeah.
But we do not have enough data from our country as to what are the circulating types in our communities. So I want to put a pitch out there that we also start doing more research on our own populations and not depend on what the outside studies tell us as to what circulating types are, because that will help us in actually making sure that we manufacture the vaccinations with the kind of types that are circulating.
Those genotypes, yeah.
Absolutely. So it's important for us to also be looking into what are the circulating genotypes in our population. So we should be considering those research components as well.
So I think the first step in this component of research would be doing the HPV genome testing as the screening method in all the women. isn't it?
Absolutely.
Yes. So that is how
Absolutely.
we
So
could get the data
that's
out
my
of it.
pitch.
Yes.
That's my pitch for
Exactly.
bringing us back to screening.
Yes.
Now, the government is recommending that we do cervical cancer screening using visual inspection with acetic acid. And the outlines, they say 30 to 65-year-olds using VIA is considered cost effective in low resource settings. Yes and no. Yes, in cost resource settings or limited resource settings, in sub-Saharan Africa, it worked fantastically. It worked great because a large proportion of the women were living with HIV. They did not have enough resources on the ground. So using the community health workers to screen using VIA worked out very well, and it helped. That same model is failing miserably in India.
Yes.
And this is our experience since we've been trying to do this since 2010. We had OBGYNs from the US who came and trained a whole bunch of healthcare providers in Mysore on visual inspection. And we wanted to see how to roll out VIA in our populations. There were several things that happened because of that. When we told somebody you were VIA positive, you needed to get treated with cryotherapy or thermoablation, the women would jump out of the table and say, wait, I need to get permission from my husband or from my mother-in-law before you can do anything
Do
to
any
me.
procedure.
So we have that issue of agency, women not being able to make decision for their own healthcare. Second, when she would tell that she needed to go and get permission from her family to get any further procedures, the family would say, wait a minute, let's just go and get a second opinion. So they would go to the closest place where they could go and get a second opinion. And what would the healthcare provider there say? They would say, well, you have completed your childbearing. Just get a hysterectomy so you don't have to worry about it.
Yeah, very
So
true.
I take responsibility for this. Since we rolled out the VIA program, we have seen villages of women who have had
hysterectomized.
Yes. And I partly feel responsible for that. So what we did is we quickly moved away from VIA. We just felt that was not working because VIA has other additional challenges, lack of training. You have to consistently train when you have to be doing VIA. We have issues with no way of evaluating or measuring quality. Quality metrics are missing.
It's a subjective errors.
Exactly. And then you have very high rates of false positivity because you can have an abnormal VIA for so many different reasons.
For infections.
And you also have lack of personnel and resources.
Yes.
So all of these things became very clear to us, and we said, okay, we're moving away from VIA, and we moved into HPV testing. So we would do clinician-collected HPV tests. Then we moved to self-collected HPV tests. And now we actually go into the villages and we use mobile clinics to do HPV testing in the doorstep of the women. So we have over 80% uptake of screening, which is unheard of.
Very good, very good, excellent.
Because current rates are less than 2% in urban communities and less than 1% in rural communities.
Yeah, yes.
But in our communities, we have over 80% uptake of HPV self-collection.
Wonderful.
So we can change the paradigm. Now, people would say, well, HPV testing is expensive.
I don't agree on that.
Well, exactly. So I think it is a question of demand and supply. When we start expecting more, the industry will race to that challenge. And it will also help us with reducing the number of unnecessary hysterectomies that we are going through right now and trying to understand what are the circulating HPV genotypes that will influence our vaccination schedule in the future.
Yeah.
So in every which way, the screening and vaccination are interconnected. Yes, and it's all related to the HPV testing and HPV vaccination rollout.
Yeah. So as you said, Dr. Purnima, I have switched over to you know Hassan. I'm a very small town, and most of them are rural women who come to us. I have switched over to HPV almost 4 5 years back, and initially the costs were quite high. But I was able to convince them and ask them to come back again, and I tried to give them the minimum price I could. I got tied up with the Adyar Cancer Institutes. I was getting subsidized prices. And then now it is a routine now. I only do the LBC if they are less than 30. Otherwise, I'm routinely doing the HPV test with the hybrid genotyping. And we have been able to bring down the cost considerably.
Exactly.
Because as you said, the demand for the HPV kit from my clinic is high. So the supplier immediately brings down the cost because he doesn't want to lose me to some other competitor of his. So we are
Correct.
doing HPV tests, and I've been promoting this to all our colleagues all around Karnataka that please switch over to HPV testing. And if you have any issues with the logistics or the things, we can help you out. And it takes just about 2 minutes of our time to convince that couple or family or woman who comes to us, and I tell them, you cut costs in something that is not necessary this year. Maybe a new clothes, your festival is upcoming now. Don't just forego that new dress you're going to buy for this season. You get your HPV test. And now, by word of mouth, I have women coming back, one for screening with HPV. They don't hesitate. I tell them this is what is going to cost. The results are going to come. Once the results are come, we have these ablative measures which can avoid the hysterectomy for you because you need your uterus. It's not just for childbearing. You need your uterus for it. It's a very necessary organ. And they also come back with the children for vaccination. So
That's
this is
wonderful.
a positive impact that we are seeing in even the rural areas. It just
I
takes.
think it's also important that we get women to understand the bone health, osteoporosis.
Yes.
All of this is connected with
Yes, true.
our
It's all
reproductive
connected.
health.
Yeah.
Yes,
They
I
need to
think we
understand.
need to kind of,
Yeah, the early
absolutely.
hysterectomies are going to have a huge impact on their non-communicable diseases, on their bone health, on their mental health, on their sexual health, as the whole midlife. Their whole
Yes.
midlife is going to go for a roller coaster if they are hysterectomized at an early age. I think we need to tell them that.
Yes, absolutely. I agree with you.
Yeah.
So in Mysore, what we are doing is we have a hub and spoke model. What we are doing is we are reaching out to all the peripheral communities, the indigenous tribal villages, tribal hamlets, rural villages. We go in there with self-collection of HPV.
It's
And all the HPV positive women are then triaged to our satellite clinics where we do the colposcopy.
colposcopy.
So that hub and spoke model is what is working for us. And we also have the HPV genotyping. We can give you all the HPV genotypes, high risk types, 14 types. So that's another thing. So if people are interested, we would be happy to serve as a site for you all to test. So you don't have to invest in
Yes.
all of this equipment. We can capitalize on the resources that we have and help each other out to make sure that everybody benefits from it.
Yeah, that's excellent, Dr. Purnima. I will definitely get in touch with you so that we can spread our wings further, say that all women are covered. Because, as you said, there is one hurdle which we are facing. Practitioners are doing the HPV test, but many of them are not colposcopists. Many of them do not have the ablative equipment in their hospital. So they have a mind block saying, what next now? Okay, HPV 16 has come positive. What do I do now? So this is again, we have taken up this training for colposcopy, asking every practitioner to get trained with colposcopy. And either you do the colposcopy and of course the thumb ablation and the cryocautery, because in my own practice, I have been using both of these since many years, and we are seeing excellent results. Women are happy, their health has improved, and none of them have lost the uterus. We have helped preserve many a uterus in our region. I think that's how the future has to be. We people have to look forward to the future. And I would like to ask you a few more questions about your Prerana Healthcare Foundation that you have started. And it is such an excellent gesture by you coming back to your hometown and working in home ground and seeing that women have a better life.
So thank
yeah.
you for giving us the opportunity. So Prerna Women's Health Initiative came out of the work that I had started in 2005. The whole objective was trying to see how we can, let me back up. The reason we wanted to do that was almost all the attention to women's health was given for the time the woman was pregnant.
Pregnancies. Only the safe
That was
mother.
the only time
Yes.
she had attention.
Focused,
And even
focused.
that attention was to
Yes.
make sure that she had a healthy baby.
Yeah.
The minute the baby is born, we forget about
They
the
don't
woman,
even look at her. They don't even.
which is unfortunate.
Yes,
So,
even in the labor room, we see that the moment the nurse or the assistant goes and says you delivered a baby girl, baby boy, and then the obstetrician finishes, we finish up cleaning up and all the work, and we step out of the labor room. There's nobody there to ask how is she.
exactly.
They're gone.
So imagine even at the most critical point, if they're not thinking about her, what about the rest of the time?
Later on,
So
later on.
our objective with Prerna Women's Health was access to healthcare across lifespan. So we start all the way from when she is a baby, as she is growing up into adolescence, and we are focusing more and more on older women,
Midlife and menopause.
premenopause, postmenopause, across the lifespan, trying to provide services for these women when nobody else is thinking about them.
Thinking of them. They
At the same time, if a woman is not present in a house, that house falls apart.
Yes, true. That there is
She
a
is the foundation. And I vouch for that because I was raised in a family where my father passed away when I was 4 years old. So my mother, as a single woman, raised 3 children. I cannot imagine what my life would have been if she was not around.
so strong.
So
Yeah,
women are integral, not just to the house, but to the society, to the community, to the world. I think this world would be a better place if women were in leadership position as well, because they
totally
make
agree.
far
I
more
agree.
sensible decisions than what we're seeing right now in the world.
I vouch for that. Yes, I totally agree on that.
So that's what Prerna Women's Health Initiative is. We focus on the disadvantaged populations, women who don't have access to healthcare. How do we get them to come in and provide them with services? But all of our services are always, before we provide any services, we have a very strong education and awareness components involved in it.
That's
so
most
everything
important.
precedes education and awareness, making sure they understand what we are offering them and they have the agency to decide what they want from us, and then we provide them with the services.
That's excellent, excellent. And I think there's a lot for us to take home from that, where we would like to take up the same module because we are doing a lot of educational programs. And Dr. Sunita just spoke to you about the Know Your Number program. There's a Sampurna program which encompasses nutrition from adolescents, preconceptional care, nutrition, and there is one module on menopausal health. That is the Sampurna. That is what the Sampurna has. It has the complete profile of the woman. So we are focusing on her menopausal health, bone health, her nutrition, her exercise, lifestyle, and what are the supplements she need to take. And we speak about menopausal hormone therapy and non-hormonal therapy, depending on whatever profile they would like to choose on. So this is one program, and Know Your Number, as Dr. Sunita already told you, is that every woman needs to know her height, weight, blood pressure, and her thyroid, because we know these are the things which are responsible for the non-communicable diseases and the health impact in her midlife and thereafter. So
I think it's also important to include blood group.
Yes, no, blood group is there.
Everybody to know their blood group.
The blood group is also there in that. There's a blood group, thyroid, blood sugar. I will share that to you. And I think Prerna is also doing a wonderful job. And we being very close to you, will definitely take up this program and try to work on the same platform or on the same protocols so that we can reach far. Though we are doing this in Hassan, we have been doing it and going into the villages, going to the schools. And I, for one, always believe in education first before I give the services, because they need to understand what it is, why we are doing all these things, and what is the disease and how we are going to address them. So as you rightly put it across, education has to be the first prong of our program. Once we educate and give them the awareness, automatically things fall into the circle, and one by one they fall into place. It makes things easier for us to provide the services, and their compliance also improves.
I think one of the pieces that we should be doing more in terms of our education and awareness is, for example, for screening, to be bringing in more women who have been treated for cervical cancer to come and talk about their experience, like testimonials of women, so that the community understands the challenge if we don't screen early, what is going to happen.
What happens?
And then also the other piece that I think we have grossly neglected, and this is the part that I'm working more on now, is women who have completed their treatment for cervical cancer. What next?
What next?
Because these women are going back into the community.
Yes.
But the very simple questions they ask is this going to come back? When is it going to come back? So we don't have, doctors don't have the time to sit down and explain all these things to the women. So one of the pieces that we are trying to do is see how we can help women when they integrate back into the community. And these women can become champions, advocates for us in our fight against cervical cancer. Give them a reason to come out and do other things besides just feel like, oh my God,
they feel more meaningful. They feel that life is more meaningful, and they are of use to somebody.
Absolutely.
That feeling
Their
of
lived experience is going to help other women. And that's a part that we have not done enough. I think Tata has some, support group meetings for cancer survivors. And this is another thing that one of the survivors told me, why do you call me a survivor?
I know. Fighter.
So we need to find other ways.
A terminology.
Yeah.
Because we want them to survive. See,
correct.
The impact.
But that doesn't, but also what we're saying is, by saying we want them to survive, we're saying you are going to die.
Okay.
Because we don't say that to others. Somebody who has had a stroke, we don't tell them you're a survivor.
You're a survivor. We don't tell them you're a survivor.
We don't say that. So why are we calling them survivors? So I think words have power.
We have to play. Yeah, we have to play.
We have to change our language, what we use. And this was a very
pertinent point. A very pertinent point.
We need to find these champion advocates who can help us with the awareness programs, not just for screening. Also, we get young women or young boys and girls who are vaccinated to come and talk to their peers.
Yeah, that's what I want to say. Those who get vaccinated.
Our study, we did a study.
And those who got screened also, they need to speak. Exactly. It's a simple test. I just came in and went out like this. And now that they told me it's negative, I feel much better. Or if it was positive, I got my thumb ablation done and I'm fine.
Yes. I'll give you a story what happened. When we went into some villages for screening, we were chased out with machetes in their hands. Men chased us.
Oh my God.
We had to run and jump into the car and go back because they were under the impression that we were stealing kidneys from the women.
Okay.
Because we were doing pelvic exams, they thought we were stealing kidneys. So they have a right to have this kind of...
They need to know what we're doing, right? Yeah.
Because historically, we have done a lot of harm by, with the sterilization programs. We've done a lot.
Similarly, the mass vaccination programs had some rumors going around in the country just 2 months back. Yes. We had the activists fighting against the mass vaccination camps.
Exactly. So I think it's important that if we bring somebody who has gone through screening to come and say, hey, I went through it, my kidneys are still there, nothing happened to me, is important. And we did a study looking at what were the most important factors that would influence catch-up vaccinations. And one would think it would be the high cost or the side effects or the distance to where. Surprisingly, what we found, we used a technique called conjoint analysis, which is a marketing economic strategy to look at what are the combination of factors that influence vaccination uptake. And we found that family support and peer influence are the largest predictors of vaccination uptake. Yes. If we said, my friend took it, I'm going to
They will
take it.
take it. Yes.
And if my family says I should take it, I will take it.
I will take it.
Doesn't matter how expensive it is, doesn't matter what the side effects are. But if my family tells me and if my friend has taken
I
it,
will.
I'm going
I
to.
will. Yeah, I
So
think I agree with that.
we need those
Those
advocacy.
ambassadors. We need those
Yes.
and they as ambassadors. So that's what when any girl takes a vaccination, I am gender neutral. I do vaccinate the boys also. I do promote vaccination for boys also, and parents do come and take it. So when they take the vaccination, I tell them, please take your photograph and put it on your status. So the moment
Yes.
they're going to ask you, what is this? Then you'll say, I got my HPV vaccine today. Get yours.
Yes.
And that is
Yes.
working. They're coming back with friends.
Excellent.
That's the
So I
future.
think that this is what is going to help us in India. And
Yeah.
with how rampant social media
Social
is,
media works.
so what you're talking about, taking that picture and putting it on their DP profile for WhatsApp is going to make a big
Yeah, next day,
difference.
100 of them will say, what did you do yesterday?
Yes.
So I think that was a wonderful discussion about the facts, the fright, and the future. And the future looks very promising with people like you around, Dr. Sunita ji around. I'm sure that we would all put our hands together to fight this cancer, which is completely preventable with very low hanging fruits, as you said. Just a simple vaccine, which is very accessible nowadays, and a simple screening procedure, which is also accessible and affordable even in the small towns around India. So, just the last word to conclude the session, Dr. Purnima.
Well, I want to say for us in India, continued investment in research, policy development, and implementation of evidence-based interventions. These are very, very important for achieving our goal and for ensuring equitable access to cervical cancer prevention and care services in all our communities. And I think each one of us has the power to make a difference.
Great. Thanks a lot, Dr. Purnima, for taking time out and spreading your knowledge and guiding us forward as to the positivity. And as you said, putting our hands into research. And I'm sure the future is very bright for India. Thank you very much for being with us here. Good night.
Thank you so much, Dr. Varti.
Thank you. Thank you.
Good night.